This program is brought to you by Emory University.
Yay! Okay.
Okay, hi. Hello all. Thank you for coming to our, I think, fourth Ebola Forum as part of our larger series. And it's very nice to see you all here on this kind of day. Our topic today, as you can see, is Ebola, religion as obstacle and asset. And as you will see, this is a topic that some of our speakers are, going to reframe the very topic that we're supposed to be talking about in wonderful ways. So our speakers today are John Blevins, who is on Skype from Kenya. We're not doing video because it makes a challenge in the audio. So we're just going to go with video, but he is in audio. He's in Kenya. John Blevins is an associate research professor in the Hubert Department of Global Health at the Rollins School of Public Health at Emory. He serves as the acting director of the Interfaith Health Program. He holds a secondary faculty appointment in the Graduate Division of Religion in the Leone Graduate School. Dr. Blevins coordinates many of the international activities of the Interfaith Health Program with a focus on developing sustainable programs with faith-based partners in East Africa, which is where he is right now, to provide HIV services and to address the social structural factors that contribute to increased vulnerability for HIV infection or disease progression. Dr. Blevins is trained as a practical theologian, and his scholarship has focused on religion's influence on our understandings of sexuality and on religion's impact on global HIV responses. Because we are working with Dr. Blevins off-site, I'm just going to introduce everybody at once so that we keep the challenges to a minimum. Dr. John Hanciles is the D.W. Ruth Brooks Associate Professor of World Christianity and was born in Sierra Leone, but has also lived in Scotland and Zimbabwe before coming to the United States. He is the author of Euthanasia of a Mission, African Church Autonomy in a Colonial Context, and Beyond Christendom, Globalization, African Migration, and the Transformation of the West. He's written and published mainly on issues related to the history of Christianity, notably the African experience, and on globalization. His current research aims to survey the history of global Christian expansion through the lens of migration. And we thank you very much for coming today. Professor Emmanuel Lartey comes from Ghana, West Africa, and holds degrees in psychology and statistics, in pastoral theology, religion, and health, and a PhD. He's the L. Bevel Jones III Professor of Pastoral Theology, Care and Counselling, also at Candler School of Theology. Dr. Lartey has served as chairperson of the British and Irish Association for Practical Theology, president of the International Council for Pastoral Care, and at present he's the managing editor of the Journal of Pastoral Theology. Professor Lartey's latest book is titled Post-Colonializing God and African Practical Theology. So, John Blevins in Kenya, are you ready to do your talk?
Sure.
Great. And Keisha will follow your IM instructions as to how to move the PowerPoint. So off you go. Thank you.
Thank you, Pamela. Hi, everybody. Keisha, if you could make sure that we are on the slide that has the first bullet point that says obstacle or asset to what?
Got it.
Thank you. So as Pamela said, I work in the Interfaith Health Program, and long before I became part of IHP, that program had been working very hard to get public health to pay attention to religion and to see it as a powerful social force that could affect health at individual, community, and societal levels. Some of my predecessors even coined a term for that called religious health asset or religious health asset mapping. They argued that religion is an asset to community health. I've always understood both the argument they make and the impetus behind it in framing religion this way. They had to get the attention of their public health colleagues. I even agree with the point they make, but I take issue with what it doesn't say. This perspective is too simplistic. Religion is not always an asset to health, and very few assets are ever truly assets for everyone in a community at all times. That's been the criticism I've made internal to my field on seeing religion too simplistically as an asset. And so I have some affinity with the title for today's lecture, but I have to say that in relation to the most recent Ebola outbreak, I do actually think that religion has largely, maybe not completely, but largely been an asset. Many of the countless women and men who work both in faith-based, civil society, and governmental health centers have placed themselves in the midst of this epidemic as medical providers or public health workers, family members who are infected or affected, care for loved ones, and they do that both as family members or medical professionals and as people of faith. They simply don't see the dividing lines that we set up. And while I have some pretty strong criticisms with the way that some medical missions programs from the United States are carried out, nonetheless, I have a deep appreciation for the motivations of the U.S. medical mission workers who are already living beside and working with communities in West Africa. They really are, I believe, testimony to the ways in which religion can be an asset for health. So I want to turn this question around today, and I want to ask, instead of religion as obstacle or asset, I want to ask, has the public health response to Ebola been an obstacle or asset? In asking this, I want to say, first of all, that I promise to get to religion straight away, but I want to explain why I believe this question is worth asking. If we don't, our public health practices are left off the hook in a way. The field doesn't have to assess itself in relation to the religious values of the people in West Africa. Rather, religion has to be assessed to see when it aligns as an asset or it has to be dealt with as an obstacle. And I would argue that in some important ways, some public health responses have missed the mark in relation to the priorities and the values of the people of West Africa. And many of those values are religious in very profound ways. Two quick caveats. In saying this, I in no way want to minimize the bravery of public health workers. I am impressed by it, and I'm in awe of it, and I am grateful for it. And second, I am always impressed by the ways in which my colleagues in public health get things done. It's kind of jaw-dropping to know how people will move halfway around the world to respond. And so my points today are quite limited in their scope. I believe that public health saves lives. That's clear. But I want to examine the ways in which public health initiatives have been perceived by communities in West Africa to actually be obstacles, and argue that we need to ask this question so we can understand the lessons to be learned. Next slide. To do this, I want to look at the two brief examples you see before you. The protocols that were originally developed by the World Health Organization and the CDC in 1998 on the burial of the dead, and a revised protocol in 2014, and then a 72-hour national quarantine in Sierra Leone that was enacted in September 2014. Next slide. I find this quote on this slide to be powerful. Burying people without prayers is like dumping the remains of a dog in a hole. It's by a sheikh from West Africa, from Sierra Leone. And it's a powerful example of just how initially public health did not take into account the importance of religious belief and faith and practice in early protocols for removal of the bodies of those who had died from Ebola. The graph you see on the screen here is the weekly incidence of Ebola cases from the beginning of 2014 up until September 2014. If you look to the right-hand side, you see the cases literally explode off the page in August and September. Those last 8 bars are the last 8 weeks of August and September of 2014. This was when Ebola came home to Emory Hospital, when we saw cases here. But for the people of West Africa, Ebola had already been around for 8 months, and it was growing rapidly. It was a very frightening time for the people of Sierra Leone, Liberia, and Guinea. And we felt some of that panic here in the United States. We were beginning to ask ourselves where that red trend line would take us, and we wondered whether the outbreak would repeat itself here. Next slide. By the end of September, it seemed that that trend line was taking us into uncharted water. This was the headline in the New York Times on September 25th of last year. Ebola cases could reach 1.4 million within 4 months, the CDC estimates. Next slide. And then the trend line changed, and it changed really rather remarkably and dramatically. Starting in October, weekly incidents plateaued for a number of weeks before then trending sharply downward. I want to explore what happened with this, but before that, I just want to remind us that we are not out of the woods yet with this epidemic and this current outbreak of Ebola. There are still cases, and we've actually seen some spikes upward in the last few weeks. Nonetheless, we have seen an encouraging trend line as those weekly incidents graphs show you. Now, there were undoubtedly a number of factors involved in the decline, but I want to explore one where religion shows up front and center, and it's the burial of the bodies of those who had died. Next slide. So the graphic you see on this page is the cover of a protocol that was published in 1998, co-published by CDC and the World Health Organization. In this most recent outbreak, when WHO dispatched its staff to West Africa, they used this protocol, written in 1998, 17 years ago. And they implemented those protocols at country level with the support of all the ministries of health in West Africa. Religious faith shows up exactly one time in the entire protocol on burial. There in section 7 is one sentence. Be aware of the family's cultural practices and religious beliefs. Help the family understand why some practices cannot be done because they place the family or others at risk for exposure. Now, it's clear that the body of one who has just died from Ebola is quite infectious, probably the most infectious it will be. But to simply tell a health worker that they have to tell a family why they cannot practice deeply held beliefs and express those beliefs in practice is unrealistic. But this was the protocol, and yet many families were clearly ignoring it. Next slide. And so WHO found itself in a bit of a panic, and it simply didn't know what to do. They convened a group of religious leaders in late September and released a new protocol in early October. In partnership with those religious leaders and with faith-based organizations, WHO developed that protocol in which religious burials were modified, but they were still carried out. They developed separate, extensive protocols for Christian and Muslim burials, and they provided ways to implement them in the local community context. And then those FBOs themselves identified national religious bodies and pastors, priests, imams, and lay organizations that can help to build support for such modification, arguing that it was a matter of faith to do it because doing so would help save lives. Pay attention to that. Religious and faith communities agreed to the modifications as a matter of faith, not as a matter of public health. Next slide. Now, I have been trained in theological and cultural studies, but I've been around my colleagues in the quantifiable world of public health long enough to understand that correlation does not equal causation. So I'm not claiming that the change in protocols for burial single-handedly caused incidents to decrease and help us to begin to see a different outcome from this current outbreak. There were, as I said before, a number of factors that undoubtedly contributed to this. But the correlation between the drop in incidents and the adoption of new burial protocols that respected religious expression gives us a legitimate reason to ask whether respectful attention to religious beliefs and practices could have been one of those responses that contributed to the decline. Many within both faith-based health systems, both at national and global levels, and within public health responses. I heard World Health Organization officials speak on this just last week, do believe that it was one of the key factors, although not the only one. Next slide. The second example I want briefly to describe is of the quarantine in Sierra Leone. The photo you see on this slide is Freetown, Sierra Leone at rush hour on Friday of the quarantine. And a quick hat tip to colleagues at World Vision who presented on this last week in a conference I was at here in Nairobi. Next slide. So the context in which this quarantine was enacted is that society was in a panic. The nation was at the height of that incidence curve you saw a few slides back. Globally, in the week in which the quarantine was acted, over 800 cases of Ebola were reported. There was increasing anxiety. People were starting to avoid schools, offices. They weren't taking their children out. They weren't going to market. Most importantly, they weren't going to clinics and doctors because that was where people died. They were, however, still going to churches and mosques. The quarantine was enacted from the 19th of September until the 21st of September. And there was a sound public health rationale. Door-to-door visits to check for anyone infected in the home, to evacuate those who were infected for care, and to educate families on ways to minimize transmission. Next slide. There may have been sound public health reasons, but in some quarters, the quarantine was met with a great deal of suspicion. People wondered whether the government was taking family members away to treat them or to kill them. Why was the quarantine enacted on days of worship? Some religious leaders either voiced deep suspicion of the government or they called for the quarantine to be ignored outright. In this context of growing fear and anxiety, a group of national religious leaders mobilized themselves. The government did not call upon them. They mobilized themselves to calm frayed nerves and to respond in a different way. And they were leaders, both ordained and lay, who had been part of a variety of faith-based responses to HIV. Now think about why that might work. If you want to know how to understand fear and stigma and suspicion, if you want to know how to respond to religious messages that can fear such fear and stigma, and how to respond with alternative messages based on an ethic of compassion and mutual care, then look at strong, sustained, compassionate, faith-based responses to HIV. The lessons learned from the HIV epidemic provided a religious narrative of calm and compassion that challenged religious messages of suspicion and fear. And they offered ready-made organizational capacity and networks that were adapted and mobilized to respond to Ebola. Next slide. And so I am more than willing to acknowledge that religious beliefs and practices can either be an obstacle or an asset. But I would also argue that Ebola has shown us that public health beliefs and practices can also be such obstacles or assets. And I can't help but wonder if the common element when either functions in this way as an obstacle is simply a blind dogmatism that fails to see as valid any other way of making meaning in the situation. The good news, Christian theologians here might use the word gospel, is that the common ground built on respectful collaboration is entirely possible, and it has happened in response to Ebola. Ebola shows us that we actually have a broad common ground on which to build this, and that is a deep appreciation for the intrinsic value of human lives. Thank you.
Thank you so much, John. Now Professor Hanciles will talk to us about, from his perspective, religion. Thank you so much.
Good evening. You know, it's impossible to deny that the topic under consideration has great poignancy. But as a Sierra Leonean, I feel I suffer from two particular handicaps. The first is I have an intimate connection with this world that we're describing, and so I feel I have to work harder than my colleagues to maintain rigorous subjectivity. The second is that there is a glut of data on what has been going on, efforts surrounding Ebola, but the glut of data is not matched by careful analysis. So much of what we have to rely on is incomplete, subjective, or even emotive and anecdotal. So some of the arguments and analysis presented here must be considered provisional. Now, Africa is home to 16% of the world's population, 50-plus countries, thousands of cultures and languages. You don't want to generalize about Africa. But I would suggest that there are two areas where generalizations can be made with a high degree of safety. The first is with regards to religiosity. Africans and African societies are deeply religious. A 2011 Pew study concluded that Africa is the most religious place on the planet. In Africa, to quote Yale professor Lamin Sane, religion is the primary category for knowing and living. So that's the first. The second area of generalization has to be the strong communal bonds and solidarity within African societies at the familial and tribal levels. The emphasis on the collective is universal. The bonds and obligations associated with family ties and group identity permeate all social relationships. And since African cultures are ancestral, these ties and obligations are attended to with the greatest intensity in relation to burial of the deceased, as you've heard. Now, I want to talk about African religions, the responses that have been generated within them, with a primary focus on Christianity. Generally speaking, West Africa is home to some of the world's fastest growing Muslim and Christian populations. In the last century or so, Christianity has grown faster in Africa than anywhere else in the world. The continent is home to a quarter of the world's Christians. That said, of the three countries at the center of the Ebola epidemic, only one has a majority Christian population, and that is Liberia, which we're told is 86% Christian. Putting these distinctions aside, the African predilection for spiritual power means that all religious traditions exhibit a form of spirituality that is oriented towards strong emphasis on divine healing, an understanding of evil as existential, spiritually potent, and even a personalized reality, profound consciousness of the limits of human capabilities, strong beliefs that both material prosperity and disastrous calamity have supernatural origins or dimensions. And finally, a strong expectation of divine intervention in daily life in response to appropriate religious ritual and practice. So, given the pervasive religiosity of African societies, it should not come as a surprise that the epidemic was widely viewed in spiritual terms amongst both Christians and Muslims. Attendance at church services and Christian meetings rose dramatically as people sought solace, prayers, deliverance, and so on. In Sierra Leone, there's a long history of Muslim-Christian coexistence, including intermarriage, and it is even reported that many Muslims also flocked to churches and revival meetings. All this is to say that for these deeply religious societies, the catastrophic nature of the Ebola epidemic evoked even deeper responses within religious life and faith practice. Now, the predominant religious instinct meant that the disease was widely attributed to spiritual causes. It's described as demonic, an attack of Satan, the work of the devil, and so on and so forth. However, I should clarify that the spiritual response did not preclude pragmatism. In churches and mosques, handshakes and hugging were banned. Attendees were required to sanitize their hands before entering religious gatherings. In some churches, each worshiper's temperature was taken on entry and the data recorded on a label that was put on them for everybody to see, to reassure others. Seating was spaced out. This was so drastic in some churches that they had to adopt 2 services. And in one cathedral in Liberia, the priest delivered Holy Communion wafers with tweezers. For all this, there are ways in which religious affiliation and identity represented a formidable hindrance to efforts to combat the Ebola epidemic. Let us allow that the ingrained cultural habits and social instincts of African communities emphasize personal interaction and physical touch. All forms of caring behavior and relational etiquette became potentially deadly in the context of the Ebola epidemic. So, there were genuine concerns that evangelical churches, which hold thousands of faithful in services promising healing, could be sites of new transmission chains. Even the promise of healing, you could argue, could psychologically lower consciousness of the fatality rate of the disease, was still cause the faithful to keep loved ones who fall ill in their homes longer than necessary in expectation of divine healing. And since healing practices also rely on the laying on of hands, you guess that was also a problem. And in fact, one of the earliest recorded cases of Ebola in Sierra Leone involved a traditional healer who claimed to cure the disease. So, but by far, the most serious and daunting area in which religiosity clashed with scientific rationality was in deeply rooted burial practices. This is what you've just been listening to. The burial practices are prevalent among all religious groups, but particularly entrenched in traditional religion and Islam. In the case of Islam, the fact that these practices included specific ritual proceedings enshrined in Islamic law rendered the practices most difficult to change. Islam requires family members to personally wash the corpses of loved ones from head to toe, following specific procedures, and several family members participate in the posthumous bathing ritual. In fact, in cases where the deceased are either famous or highly regarded Muslims or even Islamic scholars, the water used to wash the body was collected and young boys and other members washed their faces with it. And of course, since Ebola victims are more contagious when dead than alive, these widespread burial practices not only increased with the spread of the disease, but also accelerated the spread of the virus. The facts on the ground appear to bear this out. Organizations claim that 60 to 70% of new infections stemmed from burial practices. And it is also difficult to overlook the fact that the transmission rates of the disease slowed down much quicker in Liberia, which has the lowest or the smallest percentage of Muslims. Although there are other arguments in Liberia, it's mainly urban, there's an intellectual class, and so on and so forth. Friends, this issue of burial practices highlights 2 critical areas for our discussion. The first, that the epidemic was more than just a health issue. It had deeply religious or cultural dimensions that had to be addressed. quite simply addressing a range of ideas and ideals embodied in indigenous culture is integral to any effort to stem or reverse the transmission rate. Secondly, local religious leaders, chiefs, imams, pastors, and traditional authorities have to be consulted and co-opted in the fight as full partners for a successful outcome. The vast resources and expertise deployed through Western initiatives and intervention are undoubtedly critical. But it is difficult to think of a successful strategy that does not factor in local religious agency and engagement as a critical piece. This is true even of the extensive support provided by Western churches and denominations. At least one major American church pulled out of West Africa completely when the disease broke. But for the most part, international church ministries have joined the effort, even extended their operations, supplying badly medical supplies, building Ebola facilities, pouring huge resources into the fight. But this vast global Christian effort depended on heroic and sacrificial support by local leaders and congregations. Indeed, in critical ways, the international Christian response was quicker and more effective because it took advantage of pre-existing global local partnerships and networks. One of the best-known cases is that of this Sierra Leonean doctor working with the United Methodist Church as a surgeon in Kisi, Sierra Leone. Dr. Salia was based in the U.S., but went to Sierra Leone, his own country, as a medical missionary with a strong passion to serve. He was one of the few surgeons on the ground, and of course, you know the story. He gave his life in this effort. Friends, in the final analysis, local churches and religious organizations played a massive role in the still ongoing fight against Ebola. Let me close with two related observations. The paradigm in which Western initiatives and efforts are cast as the solution to crises and problems in the non-Western world is no longer as dominant as it used to be, but it is still pervasive and entrenched. At the very least, the current fight against Ebola in West Africa exposes the bankruptcy of strategies that ignore or devalue the role of local communities and indigenous culture. Second, in some ways, global local partnerships integral to a meaningful response and indispensable for long-term success have been exemplified by Christian denominations and international ministries. In one sense, this is surprising. Global Christian relations and interactions have long been characterized by Western paternalism and prescription. But this demonstration of collaboration and partnership points to an incomplete and ongoing change in the culture and mindset of Western Christian institutions. So I want to offer this. There can be no doubt that the cultural change within African communities is absolutely crucial in the fight against Ebola. What is widely overlooked is the fact that cultural change within Western society and agencies is no less vital. Thank you.
So Professor Emmanuel Lartey will conclude the presentations, and there will be some time for discussion afterwards.
Thank you very much, and good evening. The good thing about being the third speaker in this on this panel is that most of the things that I would have wanted to say have been even more eloquently put by my previous our previous speakers. So there is a sense in which I will be drawing upon some of these ideas and also suggesting some ways in which we might deepen and intensify the work of collaboration. So the main thing that I will want to be speaking about is how we may collaborate across different disciplines and across different traditions. The first point that I want to make, and there are simply three, has in fact been made very, very eloquently by the previous speaker. To African peoples, religion is not like the clothes that we put on and take off. It is rather like the skin in which we live out our lives every day. So there is a way of thinking about issues of religion in African contexts as indeed recognizing that what is being spoken of, or certainly what is being understood and what is being believed and practiced, is not seen as something that is kind of divisible from everything else that people do on an everyday basis. Every aspect of life, every enterprise of life is understood and undertaken within a sense of that which is transcendent, that which is spiritual. And so when you speak about physical conditions and physical undertakings, these are not to be understood, or these are not understood to be, again, divorced from. It's not thought that it is possible to kind of divorce a spiritual or a religious element from all of the practices that people engage in. Traditional religion is experienced as an accessible and often affordable means of healing and well-being. And it is also the case that, certainly in terms of traditional religion, that every trained traditional priest understands herself or himself and is understood within local communities to be a locus or an agent of healing and well-being. In fact, one's efficacy and one's strength as a religious person is judged and evaluated in terms of their ability to bring blessing, the ability to bring healing, the ability to bring that which is beneficial for individuals and for communities. So there is a test that lies before every religious leader, certainly in the traditional world, and that is, do my activities promote well-being? Do my activities promote healing and health? So this becomes an important and significant way of understanding the way in which religion operates. That's the first thing. Related to that is that the spiritual landscape is rich and complex, and it is also multifaceted. So it's not easily divisible into the Christian, Muslim, African traditional religious boxes of statisticians or the graphs that we see. Fact is, the fact that a person subscribes to or is categorized as belonging to, say, a Christian denomination does not necessarily mean that that person is not going to engage in practices and beliefs that are common to other practitioners, other religious traditions, African religious traditions being the kind of host or the base out of which many people operate, who would be classified and counted as Christian or Muslim. So this interconnectedness or this hybridity or this, what has sometimes been described as multiple religious belonging, is a feature of the complexity that we are dealing with when we talk about African religion. So there is a sense in which religion is abundantly present, but also abundantly absent, because it is not a category that lends itself to removal or addition at the discretion of whoever it is that is either the practitioner or the person who is trying to work with the practitioners. So this calls forth for those who are engaging in health or health care delivery to take seriously any person or any community's total well-being, to include this complex and this rich and multifaceted dimension of human life, which we categorize as religion. And also to not expect that it's going to be easy to determine what is a religious belief and what is not, or what is a religious practice and what is not. It is far more complicated than that. And the response that is then made in the generation of health needs to take into account the complexity that we are talking about in this sense. The second thing I want to say is also being expressed, and it's to do with the tremendous motivating force or the tremendous motivating energy that comes out of religious convictions or religious beliefs. And this fuels or promotes the activities of people who are engaged in the healthcare delivery program, and particularly in the fight against Ebola. Think, for example, of Jerry Brown, the Liberian surgeon who was the medical director of ELWA, the ELWA hospital, who turned the hospital's chapel into an Ebola treatment center. So it was actually the chapel in March of 2014, the chapel of ELWA hospital, that became probably the first of the treatment centers that was designated to be an isolation center. There were no isolation centers in the hospitals at the time. It was a chapel that was treated as such. ELWA means Eternal Love Winning Africa, a non-denominational Christian mission on the outskirts of Monrovia, Liberia, that is made up of a school, a radio station, and a hospital. Well, this is but one of the estimated 40% of healthcare services around the world that are founded and funded by faith-based organizations or initiatives. I was actually in this place that Kent Bradley contracted the disease. He worked at that hospital with Dr. Jerry Brown. And we know that Kent Brantley worked for Samaritan's Purse, which also is a Christian organization founded by Franklin Graham, the son of Billy Graham. So these are examples of persons who, in a sense, are practicing medicine, practicing the science and the art, motivated, encouraged, or maybe even inspired by religious faith. I think of an ambulance supervisor called Fode Gala, who became nicknamed Miracle Man by his neighbors. He contracted Ebola, and then he was one of the people who survived. And one of the things he said on interview, I want to just briefly quote, "I'm going back in full swing. I'm not going to be afraid. I'm going to walk in to fight. a lot of people die, but I was cured, and that is the work of God. I have built immunity to it, so that is a gift. I am going to get on that ambulance. I'm going to every nook and cranny of the capital city, pick up whatsoever Ebola patient, and take them to the treatment unit. Give them words of hope, of encouragement, and try to educate people about Ebola, unquote. So here's an ambulance operator, again, inspired by a particular understanding that his recovery is part of the work of God, and so he can be a person who will inspire hope and encouragement, and who is going to engage the fight and try to do the best that he can. I believe that our major challenge, and one that is very, very evident in what happened in terms of, and what continues to happen in terms of the response, has been distrust, fear, and suspicion between the various agencies and between the various practitioners, between religious leaders of different persuasions, and between the different NGOs and different organizations that have sought to fight. So I believe that our challenge is one of working together and working against the distrust, against the fear, and against the suspicion that continues to be a stumbling block in our understanding why people engage certain things and how we might actually operate together. Public health education delivered through all of the community organizations and community leaders, including the religious ones, I believe, is really a means and dialogue in which we talk to each other, in which we seek to understand where people are coming from in relation to their particular practices and beliefs. I think that this is our only hope.
The preceding program is copyrighted by Emory University.